My name is Dr. Tyler McClintock. I'm a chief resident in the Division of Urology at Brigham and Women's Hospital and Harvard Medical School. Today I'm going to discuss our article entitled Hospital Charges for Urologic Surgery Episodes of Care Are Rising in Spite of Declining Costs. This will appear in the journal Mayo Clinic Proceedings. Over the past decade, recorded hospital costs for urologic surgery episodes of care have gone down. During that time, however, charges for these surgeries, which can be thought of as the sticker price, have gone up. In terms of the methodology for this article, we use the Premier Healthcare Database. This is the largest available inpatient resource utilization database, is an all-payer sample, and captures 20% of annual inpatient discharges in the United States. For the study period of 2005 through 2015, we identified all instances of a predefined set of urologic surgeries. This included radical prostatectomy, radical nephrectomy, radical cystectomy, partial nephrectomy, shockwave lithotripsy, percutaneous nephrolithotomy, ureteroscopy with lithotripsy, and transurethral resection of the prostate. In total, we identified 392 unique institutions performing these procedures. For each procedure at these hospitals, we extracted information on charges and costs for the surgical episode of care. Just for clarity, in this context, cost refers to what the hospital believes the institution is spending to provide the service. An analogy would be how much money it costs Toyota to produce a Camry. In comparison, the charge is the sticker or asking price. In the car analogy, this is the number that appears on the window at the car dealership. When you purchase a car, the amount you pay is somewhere between the cost and the charge. Similarly, the amount reimbursed to hospitals by private or public insurance companies will fall somewhere between their cost and charge as well. In our study, using the cost and charge data for these surgical encounters, we looked at institutional characteristics as well as trends over time. In particular, we identified significant relationships between institutional characteristics and charge-to-cost ratio. Charge-to-cost ratio signifies the degree of charge markup relative to recorded cost. Hospitals in the highest quartile of institutional charge-to-cost ratio were more likely to be safety net, non-teaching, urban, lower surgical volume, smaller, and located outside the Midwest. With respect to overall trends over time, median cost per surgical encounter downtrended from $6,824 in 2005 to $5,586 in 2015. During that same period, there was an increase in median charge from $20,210 in 2005 to $25,773 in 2015. This represented a rise in median charge-to-cost ratio from 2.96 in 2005 to 4.61 in 2015. To our knowledge, this is the first analysis of surgical charge-to-cost ratio over time. Given that urology is a surgical field with a broad array of open, minimally invasive, and endoscopic procedures, we believe that our findings are likely generalizable to other surgical subspecialties. Furthermore, we believe that these findings are an important step to better understanding current charge practices and also for informing future discussions regarding healthcare reform. Pricing of healthcare services within the United States is highly inefficient and opaque, which propagates the current cost crisis and hinders efforts to introduce value-driven reform. With the lack of transparency that exists regarding healthcare costs, patients are forced to function as uninformed consumers, oftentimes only becoming aware of prices after services have already been rendered. Though the majority of these bills are often passed along to an insurance company rather than the individual, some of this money does come out of the patient's pocket, and importantly, the overall effect of these practices still remains increased costs to the system. On the institution side, the American Hospital Association estimates that U.S. hospitals are only getting paid at a rate of 39% of total charges. Third-party payers continue to apply pressure to hospitals through declining reimbursement, and recent data show that health system operating margins have dropped to an all-time low. As such, we would not suggest that the increasing charge-to-cost ratio trend in this study signifies ballooning hospital profitability. Rather, the findings in this paper suggest that higher charges may be increasingly employed to bolster reimbursement from third-party payers. In other words, during negotiations with private insurers, it may be easier for hospitals to mitigate cuts in reimbursement rates if the starting point for negotiations is an increasingly higher sticker price. Alternatively, it is also possible that hospitals are compensating for escalating costs in other areas outside of the direct surgical encounter. Lastly, with respect to the observed downtrend in costs, this may be an indication of some degree of success in cost containment for surgical episodes of care. Patients should view these findings as illustrative of shortcomings in the current state of cost and charge practices in the American healthcare industry. Speaking broadly to these shortcomings, number one, we know from other studies that most hospitals do not have a strong handle on how much it costs them to provide care. Resource utilization, or true costs, have been shown to vary from what is recorded in hospital cost accounting systems by as much as 10 to 50%. Number two, as we and others have shown, charges are many times higher than cost and don't fully correlate with cost. And lastly, number three, as we have shown here, higher hospital charges may be increasingly employed to bolster reimbursement from third-party payers. Taken together, while this overall speaks to the inefficiencies in our system, projects such as ours can hopefully serve to better delineate current cost practices, while also informing efforts to do better going forward. Future research will be necessary to determine how the divergence of cost and charge trends seen here relates to reimbursement and profitability. This could provide some insight into the motivation behind progressively escalating charges. Given a lack of reimbursement data in our database, however, we could not fully explore those questions here. While this study illustrates innate inefficiencies within the system of how we price surgery in the United States, payment reform now seems inevitable. In this context, improving surgical cost accounting and controlling inefficient charge practices together hold the potential to lower systemic costs and thereby contribute to the further development of value-based healthcare delivery.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.